So this is how this has changed. The mean age of having their first child is now from 19.4, it has increased to 21.2 years. But the age you will have your last child, that has decreased because not much children, women are not bearing much children these days. So that is like lesser children per family. So what is the relevance? Why are we discussing this? Older women, they have increased prevalence of chronic medical condition and hence pregnancy outcomes are adverse. Reproductive age women, they are experiencing increased prevalence of CVD, that is cardiovascular diseases, related risk, and that is mostly because of obesity, hypertension, and that is again related to dietetics. So these are the few chronic diseases which are most often seen and we deal with them. So coming to the mental health, depression is one major thing and it always triggers during pregnancy. Then obesity, diabetes, hypertension, epilepsy, kidney diseases, thyroid disorders, bronchial asthma, autoimmune disease. These are the all different kind of diseases we encounter during pregnancy. So these are the incidences. Depression is like, it has a fairly high incidence, though mental health is not much stressed upon in India, because most of the time we think like the family members also think it's kind of tantrum the women is throwing. But for these kind of women who are sad, who are like who have mood swings, they should be taken very they are very vulnerable and they should be taken handled with care very delicately. Then others are like hypertension, diabetes, these are the other diseases we see. So prevalence of diabetes is also increasing and that is again related to obesity or increase in the basic BMI of women. And that again is related to the eating habits and the sedentary lifestyle we are seeing. So this is how the outcomes are there. So when it is at an advanced age, there's a chronic disease and the age is also advanced, then maternal mortality and morbidity increases much. So why reproductive age women are at risk? Because most of the women, we are lucky to be sitting here and like we are participating in a dialogue like this. But since I have done my studies from a small town, so I can see the rural women, they don't have access to health, the basic amenities of health. So less as access of health care is one thing, because there the women, they don't have so much of accessibility, they don't come for checkup. So if the antenatal checkup is not regular, then most of the time you are not able to detect the disease, or maybe you are not able to detect the disease which was previously there and it has started worsening. So then how to intervene and when to intervene, it becomes very difficult. And sometimes they land up directly in a state of labor or in a situation where we just can't help them, and sometimes we lose the mother or the child, or sometimes both also. So it has such dire consequences. Pregnancy may be the only time when low income women have health insurance, or their access at least once or twice. The family members will bring them to the doctor for a checkup. So that is one time when they will be at least brought once or twice for the checkup. Women may not be established with primary care if healthy prior to pregnancy. Care for self is deprioritized relative to care for young children, aging parents. So this is again another thing, the mindset of women in country or maybe more so in the rural areas of India, where women, they always take a back seat, whether it is healthcare or like their own happiness. So that is why they have been brought up and reared. So that is again one mindset which prevent them for the access of healthcare. So chronic diseases, and like what is the role of doctors for us? So it starts right away since the woman is planning her pregnancy, which we call it pre-conceptional counseling. And it goes up till the postpartum management. So it's not that only when the woman has delivered, our job is done. We have to follow these patients till the postpartum period, and that is like 6 weeks after the delivery. Screening and prevention, that is again very important, and we have to have a very high suspicion for some diseases depending upon the family history, and then we screen them. So screening makes us pick all those diseases very early stage, and so that we can treat them, and we can like the whole thing can end with a healthy mother and a healthy baby. So these are the different things we do, right from the preconceptional counseling, so lifestyle and diet management, antenatal care, postpartum screening and prevention of women during the intervals between the pregnancies, which is again very important, because once she has a history of hypertension in previous pregnancy or a diabetes in previous pregnancy, she is very much likely to have all these in her second pregnancy also, and sometimes they continue to be hypertensive and diabetic even after delivery. So that is again very important thing. We all know being a mom is very exhausting. Most of us have experienced it personally. And coming to the depression, which is like quite a lot prevalent, but most of the time we fail to pick it up. So when there is organic depression in the patient, we tell them to defer pregnancy till they are normal. Once they are normal, they don't have panic attacks, then only they advise they should go for planning a pregnancy. Few medications can be continued during pregnancy also, but few medications needs to be substituted. So the dose needs to be titrated, and the salt needs to be also substituted as per the pregnancy, as per the need of the pregnancy. So there are so many other medicines which have different side effects, like somnolence, some are teratogenic, some can cause preterm also. So these medicines need to be stopped, but we can't put the patients out without medications, because that will lead to like panic or anxiety attack, which has dire consequences on the pregnancy also. It can be as serious as miscarriage sometimes. And sometimes these patients who are undergoing depressions, they don't eat properly. So there is a lot of cases of intrauterine growth restriction, and sometimes the baby need to be delivered earlier also, before time. So there's preterm birth, intrauterine growth restriction, and when preterm birth, the baby needs to be put in NICU. So that has its cost burden as well. So these are the different symptoms of depression. And so these are very too much of medical things, so I'm just skipping some of the slides. So but then the gist or the crux is that we don't have to withdraw the medicines, we just have to titrate the dose and to substitute with those medications which are safe for the mother and the baby as well. So coming to the next, that is the obesity and pregnancy. Obesity is associated with subfertility also. Since I'm doing a lot of infertility, I can see obesity leads to hinders with the ovulation part also. So if our patient is obese or overweight, comes to us and we see she's not ovulating properly, then the first thing we advise is like lose some weight. Even 5 kg weight is going to enhance your fertility. So that is a very important thing. And more than half of the pregnant women who become like those obese women who become pregnant, they are at higher risk of for maternal complications like gestational diabetes, like hypertension, like venous thromboembolism, postpartum weight retention. So these are the things they can like encounter during pregnancy once pregnancy happens with excessive maternal weight. So these are the different kind of things it can cause, like gestational diabetes. Difficult to like simple things. It's difficult to do a transabdominal ultrasound with lot of fat on the abdominal wall, and even fetal monitoring at times becomes very difficult. It can cause gestational hypertension and the whole spectrum like preeclampsia and eclampsia, which is again life-threatening for the mother and the baby as well. There is increased risk of cesarean delivery also. So there's risk of stillbirth, congenital abnormalities, large size babies, like obesity in mother may lead to obesity in baby also. So these are the different things we need to see. So, and weight loss, on the contrary, it appears to reduce the risk of gestational diabetes. So there's so many studies which have proven this. So diet is definitely the first line of treatment when it comes to obesity and pregnancy. And there's a different rule. We tell them to not to gain so much of weight. So during, for a obese woman who has become pregnant, it's never eat for two. The calorie intakes are different, because that might end up in different complications like gestational diabetes or gestational hypertension. So coming to the next topic, that is gestational diabetes. It is like, that is one of the metabolic physiological changes which which a woman undergoes pregnancy, because insulin sensitization is less, and so there is a like more increased risk of becoming turning out to be diabetic during pregnancy, even if you don't have any like any if there's a family history, then you have more chances that the patient will develop diabetes. So we need to have a high index of suspicion in these patients, and there are few tests which we do, especially when it's like between 26 to 28 weeks of pregnancy. That is called a glucose tolerance test or a DIPSI test, where we just have a strong suspicion that she might develop diabetes because she has a first degree relatives with diabetes, the family, or she has developed diabetes in a previous pregnancy, or she's obese, or even she has PCOD, things like that. So for these patients, we do a glucose tolerance test at 26 to 28 weeks, and if that is deranged, then that tells that she is potentially diabetic, and so we can manage. Sometimes most of the time we are able to manage by diet, but sometimes we need medication also. And what does diabetes bring? Diabetes bring a lot of fetal complication, maternal complication, like there is organomegaly, there is macrosomia, large size baby, hence there can be birth trauma. There are a lot of congenital abnormalities in the baby also. In mother, there is preterm labor, or there's high risk of more chances of cesarean section. Even chances of developing hypertension also increases when there is diabetes. So these are the criteria we follow. So we tell them not to gain much of weight when they have diabetes. And in fact, when we put them on a diabetic diet and medications, the weight gain is slowed itself, because she is taking less of calories. So women who have GDM, they have at least a 7-fold increased risk of developing diabetes type 2 in the future. So again, there is role of following these patients even after delivery, like postpartum. So that is again very important, because some of them might remain diabetic for rest of their life. So screening, as I told you, we always do between 26 to 28 weeks of pregnancy, but in those patients who have developed diabetes in their previous pregnancy, we do it much earlier. Like maybe we will do sometimes in their first visit between 6 to 12 weeks. So these are the different trials. They have proven the role of doing diabetes test for diabetes or glucose intolerance at different phases of pregnancy. So these are the different type of complications we see during pregnancies. And the goal our goal is to keep the HbA1c about like less than 6. That is our goal. And postprandial glucose should be somewhere around 130, and fasting should be somewhere around 100. So that is why we don't like to overcorrect or undercorrect the diabetes during pregnancy, because you do overcorrection, then there is a ketosis which will happen inside the women, and that is going to affect the baby also. So then coming to hypertension, it is like 6.9% of the reproductive age women have chronic hypertension, and more so we are seeing in women nowadays, because the marriage is at a later age, and not to tell about the like increased weight and history of PCOD, all these makes predisposed to developing hypertension. And since the marriage is like the mean age of marriage has gone up, so most of the patients, by the time they visit to us in their first pregnancy, they are already hypertensive. So how do we define? So a blood pressure which is more than 150 upon 90, then we label them. That has to be like on two separate occasions, 4 hours apart, and that has to be after 20 weeks. Then it is gestational hypertension. So if any blood pressure which is developing before 20 weeks, it means it was a overt hypertension which was not diagnosed, and it is diagnosed now in pregnancy. So that is by definition. Sometimes if on spot we see it's a much higher blood pressure, then only one reading is sufficient, like 160 and upon 110, then one reading is sufficient to label that patient as gestational hypertension or essential hypertension, which on which gestational hypertension has been superimposed. So it is diagnosed less than, as I told you, less than 20 weeks, then it is chronic hypertension. After 20 weeks, then it is gestational hypertension. And pre-eclampsia is in the same spectrum, but here the kidneys are also affected, and there is leakage of protein from the kidneys also. So this is like how we, the main thing is like you have to diagnose it earliest, because in these cases we always prepare ourselves for a delivery, for a preterm delivery, because sometimes these patients can't like reach up to the 40 weeks of gestation. 40 or even term, like 38, 39 is very difficult, because their kidney is compromised, their blood vessels are compromised, so they land up in intrauterine growth restriction and preterm delivery. So in these patients, we have to prepare ourselves and the patients both, like the preparation is in the form of counseling them both for the financial setback, which they are like, they should be anticipating, because these babies, they always go to neonatal intensive care unit, where sometimes they have to stay for longer time. So that is very important. So it has all, not only like physical, it has financial implications, also burden on the patient. So coming to the preeclampsia, preeclampsia also has effect on heart vessels and on the vessels of the brain. So that ways it is very important to pick them at the right time and treat them. And the way we treat preeclampsia is like management of blood pressure is very important. We have to see whether the kidney symptoms are not worsening, that is proteinuria is not increasing. And not only this, the preeclampsia has not to progress to eclampsia. In eclampsia, the whole spectrum is there, like there is high blood pressure, there is leakage of protein, and add to it, there are fits or seizures. So even the arteries in the brain are affected in eclampsia. So we have to slow down, or we have to cut down the progression of gestational hypertension to preeclampsia. And the only way we can treat this, prolong the pregnancy till the baby is mature enough to survive outside the womb, and then we have to deliver it. So most of the time the delivery is before the due date, and sometimes to save the life of the mother, we have to abort the baby also. So here in these cases, we always put the mother's health first, and then comes the baby to us. So coming to chronic kidney disease, again chronic kidney disease also behave in the way preeclampsia and eclampsia, like gestational hypertension and preeclampsia, because there is hypertension, and because of hypertension, the blood flows in the vessels at a very high pressure, and so the growth of the baby is compromised. So there is intrauterine growth retardation, there is preterm birth, and sometimes fetal loss also. So coming to thyroid disorders, they have their own risk, because thyroid disorders can lead to right from infertility to, they can lead to miscarriages, developmental delays. So again, the key is to pick them as soon as possible. So a basic thyroid test we do for all antenatal patients who come on their first visit, because at that time you can cure them. So it is curing a thyroid disorder is very important. If it is hyperthyroid, we have medicines for that. If the patient is hypothyroid, that is she has less of thyroid hormone in her body, then we can always supplement with thyroxine, and then she becomes euthyroid. Once the patient is euthyroid, all you have to do is monitor her TSH again and again. If the patient is euthyroid, then the growth of the baby remains as a normal baby. So there are autoimmune diseases also, in which the chances of intrauterine growth restriction and miscarriages is very high. So these patients, when they come in the preconceptional period, we always tell them to control their disease, to go to remission, and then plan a pregnancy. But sometimes they become pregnant and then they come. Then the course is different, and then we have to like keep on screening them for different diseases like gestational hypertension, diabetes. From the fetus point of view, like we have to have a high risk of suspicion for intrauterine growth restriction in these patients. Then coming to epilepsy, it is very important for those patients who are on anti-epileptic drugs, they should continue these medicines during pregnancy also. Because once they throw a fit, there is oxygen shutdown to the baby, and sometimes the baby can die in the womb also. So it's very important for those patients who are on anti-epileptic drugs, they should continue their anti-epileptic drugs, and along with that, we supplement it with folic acid. So coming to asthma, asthma also because of the inhalers, we have such a beautiful tool, because the patient with asthma, with status asthmaticus, that is the worst attack of asthma. We have so much nebulizer, so much inhalers, and so different type of bronchodilators that we can easily deal with them. But only thing is that you have to be vigilant about the triggers, like what triggers your attack. That is very important. You have to avoid all those things. Otherwise, inhalers are fairly safe during pregnancy because they have just the local effect. So about the postpartum care, patients should be encouraged breastfeeding, because none of these diseases we tell because breastfeeding is very important for mother and the baby, and none of the chronic disease are contraindication for breastfeeding. So this is very important message. And coming to all these things, so there are, as this is just I'm trying to sum up, that both maternal and fetal risk are high with chronic diseases, but timely intervention is something which is always in our hand. So picking them at the right time, dealing them the way, these patients need to come to follow up very frequently, and then we can easily deal with them. So these are the different kind of perinatal outcomes, like IUGR, neonatal asphyxia, sometimes stillborn, fetal death, which we encounter during in all those women who are already having a chronic disease. So there is a critical role of primary care in preconception and postpartum management of chronic disease. Depression is the incidence of depression is very high, though it remains undiagnosed. Obesity is there. If you do a prior weight loss before conceiving, then it really helps in avoiding all those chronic diseases which can come with a baggage of obesity, like gestational diabetes and hypertension, preeclampsia, eclampsia syndrome. So the chronic diseases, they increase the pregnancy risk. They require preconceptional counseling, multidisciplinary care should be there, and it gives a better outcome. Monitoring and medication safety are the key. So thank you. Thank you for your patient hearing. Yeah, sure. Yeah. Yeah, it triggers because there is a lot of hormonal changes in the women, and sometimes the body can't take those hormonal changes the way the other body takes. So there are milder form. Primarily, we do a lot of counseling for these women. And the first step we do is counseling and support from the family members, which is very important during pregnancy and after pregnancy. But the support from the family member after pregnancy is not there, because most of the time that whole support shifts to the baby. So the mother is very lonely. So she lands up in postpartum blues. But those who have a little tendency, again, family history is very important. If there's a family history of depression in the in first degree relatives, then our antennas are alert. So we have to call them like frequently, sit with them, talk with them for a longer period of time, so that she pours her heart out. So these are the little things we do. And apart from that, there are safe medications also which we can give during pregnancy as well.
Ma'am, one more question. Ma'am, do you have any case study of HIV pregnant women? How you deal with them? Have you
For
gone through with
HIV,
any case
we
study?
have antiretroviral therapy, because HIV pregnancy we deal. There are certain center which are which government has designated. There only HIV positive patients are treated. But with the advent of antiretroviral therapy, the transmission of HIV virus from mother to baby has decreased drastically. Not only that, we even say that you can breastfeed your child also for a HIV positive mother. So that ways it has evolved. It has evolved much because it was earlier, don't touch the HIV patients. It was like that. And even the baby was like not allowed to breastfeed. But now things have changed. Thanks.
Hello. Thank you, ma'am, for the wonderful presentation, and you have brought a lot of information and the data and the statistics as well. I have few questions, and you have mentioned that gestational diabetes, all other complications related to pregnancy. Now, the marriageable age also increased, as well as pregnancy, first pregnancy also have put a lot of data. And because of this reason, complications have increased more. Are any other societal changes have brought, causing these kind of illnesses, so complications, sorry.
Basically, I like to stress a lot upon lifestyle changes. Lifestyle has changed drastically. Now people have much a sedentary life. There is a lot of exposure to so many things in the environment we don't know. But apart from that, advanced age is definitely the first and the most important thing. So increasing the mean age of marriage, because the peak fertility is in 20s, in mid 20s, you have your peak fertility. So I always tell my patients that after a certain time, you don't have to set your goals one by one. There's so many things which run in parallel, like your professional life, your family life, your married life. So that is how I counsel them. So, mean age of marriage has gone up. That is one thing. Sedentary lifestyle and lot of smoking, alcohol. These are, I can see, because earlier it was like we were reluctant to ask girls like, are you taking alcohol or smoking? But now even they are very, very much that, yes, ma'am, I'm taking so many cigarettes in a day. So that is, lifestyle is there, mean age of marriage is there, sedentary habits are there. And apart from that, I will say, like, the basic routine is also gone wrong. Like, somebody is doing a night shift, not sleeping properly, lot of social media also. Because at young age only, they'll come and they'll say, Ki, I can't sleep. Because they'll have their mobile sitting right on their head and checking your social media. So these things, mental health has gone down. And and apart from that, sexual activity at an early stage, because sometimes they have unprotected sex, they will harbor some, because this is little out of topic, but I'll definitely like to share. I see so many young girls sitting here, and then sometimes they harbor infection from their partners. They have multiple partners, and then they will harbor infection which can cause infertility in later part of life also. So these are the relevant things there.
Thank you so much, ma'am, for you. From your personal experiences also you share a lot of information. I have one more question. You have mentioned venous thromboembolism. What are the risk factors and what are the challenges to a gynecologist when you are dealing with such cases? And as a nutritionist, what role we have to play during that time?
Venous thromboembolism is like a scary kind of situation for us also, because mostly the kind of venous thromboembolism see is usually in the calf muscles, and it is like what happens during pregnancy, the coagulation factors, they increases. So the blood is in a hypercoagulable state. So there is more tendency for the blood to clot. So the one thing we can do to prevent is like being physically active is very important. There are certain activities and exercises also which we tell our patients to be up and about during the pregnancy, unless it is contraindicated otherwise, like she has a placenta previa or she has a threatened abortion. In these cases, we will tell them to curtail their activities. And we have some medicines also, like simple medicine is ecosprine will give in these patients, or low molecular weight heparin to prevent the clots. So these are the things. And when these patients have a similar history in previous pregnancy, or they have a family history of thromboembolism, or little amount of risk of thromboembolism increases with the use of oral contraceptive pills also. So certain medications are also there which increase the risk of thromboembolism. So during pregnancy also, being up and about, and simple medicines like ecosprin and low molecular weight heparin, where we have a high risk of suspicion because of family history or maybe similar history in previous pregnancy. And after delivery, we tell them to be up and about. And there are certain calf muscles exercises which we tell them to do, and most of the time we are able to tackle with this.
Thank you, ma'am, for the wonderful answer. Thank you so much for being here and delivering the lecture and sharing your personal experiences and giving insights related to venous thromboembolism, which is majority, like the cases are very limited as per my knowledge, but it's, yeah, but very scary situation for the family members as well as for the nutritionists as well. Thank you so much.
Thank you so much, ma'am, for giving your insights on the topic. Before we dive into today's discussions and events, let me take a moment to thank everyone who had made possible today. We are incredibly grateful to our esteemed speakers, healthcare professionals, community leaders, and all our partners who are working tirelessly to create a healthier world for future generations. We are fortunate to have some esteemed guests with us today whose contributions and support have been invaluable. To recognize and appreciate their efforts, we would like to felicitate them with a small token of gratitude. I kindly request HOD ma'am, Komi ma'am, Pratibha ma'am to please come up on the stage to present the tokens of appreciation. If I may please request Dr. Divya Kumar ma'am to come up on the stage. May we now request Charu Dua ma'am to please join us. Just a small announcement. We would request all our panelists as well to please join us on the stage for felicitation. May we please request Charu ma'am, Sandhya ma'am, Sonia ma'am, Binu ma'am and Shilpa ma'am to please come over the stage. May we please request Charu ma'am to step forward. request Sonia ma'am to please come forward. Our next panelist is Miss Sandhya ma'am. Next, may I please request Bino ma'am to come forward. And I may now request Shilpa Thakur ma'am to please step forward. So, well, students, we are excited to announce that we will be hosting a short quiz competition as part of the today's event. This will be an engaging opportunity to test your knowledge and compete for some exciting prizes. There's a scan code on the screen. There's a scan code on the screen, so everyone who wishes to participate can scan over. The form will be active for 10 minutes. There are 20 questions, and whosoever gathers the maximum marks would be the winner. So just 10 more minutes, 20 questions. Please don't forget to click on submit so that your quiz gets submitted on time, else your response won't be recorded. Hope everyone has scanned the code. Last 4 minutes left. Please kindly wind up with your quiz. Last 1 minute left. Request all the students to please submit their quiz. Thank you, students. We'll be telling you about the winners soon after the panel discussion. We are related to begin our panel discussion, where experts will share their insights on the theme Healthy Beginnings, Hopeful Futures. To ensure that this discussion is both insightful and engaging, I am pleased to introduce our panel moderator for today, Ms. Shilpa Thakur ma'am. She has pursued her MSc Food and Nutrition and PG Diploma in Nutrition and Dietetics. Presently, she is a General Secretary of IAPN. I welcome you, ma'am.
So good afternoon, everyone. Um, Before I begin with the panel discussion, I would like to introduce our panelist over here. So our first panelist is Ms. Charu Dua. She is HOD and Chief Clinical Nutritionist with Department of Nutrition Dietetics, Amrita Hospital. Over 28 years of experience. She is also faculty for BSc Nutrition, BSc Nursing, and MBBS Amrita Vidyapitham, and external examiner for nutrition, and she's a renowned at renowned institutes and universities. She has been Platinum Award by Alma Mater at Lady Irwin College in 2000. She's got Max Excellence Day Award under Green Belt category, Best Performing Department Pan Healthcare for 4 consecutive years. She has been the Best Speaker Award in CME. She is GEM Award for Performer of the Quarter, Quality Award for Good Performance. I mean, many awards to her credit. She is also a diabetes educator and a FODMAP certified nutritionist from Monash University, Australia. She's trained on nutrition care process. She's EC member with Indian Dietetics Association and a board member with Celiac Support Organization. She's vice president with Association of Comorbidities and Rare Diseases and vice president with IHE Alumni Association. She's NABH External Assessor for Quality Council of India. We welcome you, Charu. So our next panelist is Ms. Beenu Bhatia. She is consultant nutritionist working as AGM Nutrition Research and Development at Steadfast Nutrition. Previously, she was working with Associate Professor in Department of Nutrition and Dietetics, Faculty of Applied Sciences at Manav Rachna. She's having experience of more than 13 years, and with 4.3 years of clinical and industrial experience. She's won the Best President Poster Award at 44th Annual National Conference of IDA, AIMS, New Delhi. She's also was on the editorial board for Heal India magazine under Via Media Communications Private Limited. She has keen interest in the research interest, including public health nutrition, therapeutic nutrition, nutrition education, childhood obesity and junk food, food product development, and nutraceutical. She has guided more than 25 MSc dissertations and presented paper at numerous national and international conferences, and has more than 15 research paper publications in various journals, along with 25 article publications in health magazine and dailies. She was principal investigator for one of the year project by FSSAI on the safe and nutritious food for school, founded by PepsiCo India Holding Private Limited. And she has delivered several radio talks, participated in live programs, career counseling for community radio station. She has organized and coordinated various national and international conferences, seminar, and workshop. We welcome you, Beenu. Our next panelist is Ms. Sandhya Pandey. She is MSc Food and Nutrition with Postgraduate Diploma in Population and Health Management, Certified Diabetic Educator, FODMAP Dietitian from Monash University, Australia. Presently, she is GM and Chief Clinical Nutrition at Medanta, Medicity, Gurgaon, holding more than 27 years of experience. And she's worked as nutritionist as well as researcher at Center of Micronutrient Research for Project of Johns Hopkins University, USA, and has an experience of extensively working in the quality assurance programs like ISO, NABH, JCI, has formulated manual policies, guidelines, and SOPs for proper functioning of Nutrition and Dietetics Department. She has been honorary executive member with IAPEN Delhi chapter and certified diabetic educator and ISO internal auditor by BVQI and international triple L course certification from European Society of Clinical Nutrition and Metabolism on different topics, advanced certificate course for applied enteral pharmaco nutrition in critical care, and participated in various national and international nutrition conferences and workshops. We welcome you, Sandhya. We have our fourth panelist as Ms. Sonia Rai Vaid. She is a child birth educator and birth doula lactation consultant and prenatal yoga instructor. Presently, she is maternal and child wellness consultant with Asian Hospital, Faridabad. So we welcome all the four panelists. So, as we know, the topic for today or the theme for today's World Health Day is healthy beginnings and happy future. So we'll explore the various aspects of maternal and child health from the nutrition during the pregnancy to the importance of breastfeeding and the newborn development. So just to make you aware that the main aim for this panel discussion is to have various valuable information and practical advices for the expectant mothers, new parents, as well as to the younger generation who is contributing to the field of health and nutrition. So for the first round, we'll start on with our panelists, and my first question would go to Ms. Charu. Charu, we have heard from, Dr. Divya Kumar also, she was talking about the very famous old saying like eating for two. So we understand that this old saying as eating for two can be misleading. So how do you perceive this saying, and what does the science say about the caloric needs during pregnancy?
So at the outset, first of all, I would like to thank you, Shilpa and Manav Rachna and Dr. Divya for inviting me and talking about this topic with my experience. I hope all of you are nutrition students over here. Yes, so that is very, very important because pregnancy is a physiological stage where nutrition plays a very important role. And gone are those days when we used to say that when you are pregnant, you eat everything and anything that comes in front of you, and you have to eat for two. Like especially I'm talking about the urban population. So you need to actually assess a mother as a student when you go, and then you need to decide the calorie requirement of a pregnant mother. So you don't have to by default give double calories. The science says 350 calories in the entire period per day is an extra need. So in first trimester, you need not give more calories because that is not required. Mother is coping up, the fetus is small. So extra nutrition is not required in the first trimester. It is from the second trimester where the fetus is growing, the mother organs, and there are a lot of changes that happen with the mother. That is the time where you need to increase calories. And in the third trimester, the rapid growth further happens. So you have to aim the calories basis the weight of the mother. That also has to be taken into consideration. So first thing to assess is what is the BMI of the mother. If she's underweight, you need to plan the calories accordingly. The mother has to gain 10 to 13 kgs of weight in the entire pregnancy. But if the BMI is overweight and obese, then you need to actually make a mother gain 5 to 10 kgs of the weight, 5 to 8 kgs depending upon the BMI that the mother has pre-pregnancy.
So it's not eating for two,
Yes.
It has to be under the guidance of a dietitian, as madam has guided, like the amount of calories which has to be 350 kilocalories, but it has to be tailor made also as per the individual requirements.
Absolutely.
Okay. So my next question is like shifting to the infant feeding when we have been talking about the mother feeding now. So this question goes to Sandhya. So how does the infant formula compare to the breast milk in terms of nutritional content? And are there any kind of circumstances where formula feeding is necessary or preferred?
So thank you, Shilpa. Thank you, Shilpa, IAPN, Manav Rachna, and all the seniors and faculty here who has invited us on this platform. Thank you so much. The question that is, it's quite big actually. The first thing that everybody needs to take from here is that breast milk is the best milk for the baby. The breast milk contains all the essential nutrients, which means carbohydrates, proteins, fats, micronutrients that are required for the growth of the baby. And the first 6 months have to be exclusive breastfeeding. But it's not just the macro and micronutrients, it is also the other components like bioactive ingredients, immunity building nutrients, the bioactive factors, hormones, enzymes, which are not present in the formula feed. You can add, they try all the formula feeds, they try to add all the nutrients according to the breastfeeding, but the addition, you cannot add all these factors, which means the IgA, lactoferrin, the lipase which is there in the breast mother's milk is something that is there, and once the child has it, in the presence of bile, it gets active, which means the digestion of the milk is faster because the lipase is present in this. So which means that the bioavailability, digestibility, also the whey and casein composition in the breast milk is far better. The whey to protein casein ratio is higher. Whey is about 60%. So these things make a difference. Similarly, there's some amino acids, cysteine and taurine, which is required for the brain development of the child, is not probably present in the formula feed. So first preference always would be breastfeeding. Now the second part of the question was that in which circumstances we have to do formula feeding. So one, we have to see there can be very serious maternal conditions. The patient is HIV positive and is on antiviral therapy, tuberculosis, chemotherapy, radiation therapy, or certain conditions wherein the mother cannot feed. Now these have to be established by the treating team, the gynecologist, the pediatrician. You cannot just say. So that's one. Number two, some infants. So if it's a preterm baby, the requirements for proteins and calories are higher as compared to full-term babies, and we'll probably talk about it later. But those are the conditions where we have to ensure that the baby grows sufficiently as per the requirement. One. Other than that, there are some inborn error of metabolism, phenylketonuria, MUSD, galactosemia. These are conditions where you cannot give the mother's milk. In that case, we will have to then choose what formulas we have to give, and that's when we have to give formula feed. So the basic difference is the immune nutrition, the ability of and adaptability. The beauty of the mother's milk is that as the gestation increases, as the baby grows, the mother's milk also changes the composition of the nutrition. So that's the beauty of the breast milk. So I would say breast milk is still the best.
Yes. So we get a message that maa ka doodh is sarvottam doodh.
Absolutely.
And it is only conditionally essential formula milk in special conditions which Madam has specified. Okay. So thank you so much. My next question would go to Ms. Sonia. When we've been talking about pregnancy's needs and we're talking about the infant feeding. So you being a maternal counselor, what strategies would you recommend for the mothers who had a C-section or experienced complications during childbirth that affect the breastfeeding basically?
Yeah, thank you so much, Shilpa. So, we have to understand that when a mother has undergone a C-section or there were some challenges during pregnancy, so what are the things that we can do? Firstly, keeping the mother and baby closer so that, how the milk is produced, that when baby stays closer to the mother, the oxytocin hormone is released. And that helps in the release of the prolactin hormone, which is responsible for milk production. So keeping the mama and baby close, the baby is feeling safe, mama is feeling safe, and also milk production is happening. The second thing is educating the families about different positions that they can help the mama to feed the baby. Because if a mother had a C-section, she'll be lying down. So how can she feed her baby while in that position? So educating the families is very, very important. So that's what I feel that, educating the parents, keeping the mama and baby closer are very important factors to, promote breastfeeding and so that the mama feels safe. Yeah.
Okay, so thank you so much. So my next question would go to Binu. So we have understood that breastfeeding is very, very important. And even in case of complications also, we have a number of supportive things which we can do for mother and child to promote breastfeeding. So Binu, my question is, how important is breastfeeding in the early stages of the child development from the child's preview, child's health preview, and how we can encourage and support mothers in this practice?
Yeah, thank you, Shilpa ma'am, and thank you, Manav Rachna University and IAPEN for giving me this opportunity over here. And as per the question, for the question for the answer is like, see, breastfeeding is the foundation for the later life. So it is a very important step in the life of a child also and mother also. As already Sandhya ma'am has also told about that it provides you all the nutrients that is there, all the macro and micronutrients are there. So for first thing is for the nutritional outcome, that is the best from the breast milk that is there. And as we are talking about the nutrients, see, it also provides DHA, which is a very important fat, essential fatty acids, which is required for your brain development. And for a child, like a newborn child, there are a lot of neurons which are present, and they are making the base for the brain development. So that is a very important part as per the nutrition. Other than that, all the fat, carbohydrate, proteins, vitamins and minerals, they are important part. Along with the nutritional outcome, immunity is also an important part. Likewise, Sandhya ma'am already told you that the immunity factors are present in the breast milk. So that leads to the stone of immunity for a child in the later life. Like all the respiratory disease or ear infections, a child may not suffer who is breastfed regularly, like for the exclusive, if a child is exclusively breastfed, he may not suffer from all these infections in the later life. And along with that, there is another thing, health concerns for the child as well as for the mother also, because mother is also going through the postpartum problems during that phase. So in that case, breastfeeding also helps in the health of the mother also in combating with the postpartum contractions. It reduces the uterine it contracts the uterine basically, and it also reduces the bleeding during that phase. So it is important for mother also, and in later future, it also reduces the risk of the breast cancer or ovarian cancers in the mother. So it is an important part for both mother and the child. And other than that, as Sonia ma'am was also saying, that skin to skin, when there is a touch, skin to skin touch is there between the child and the mother, it leads to the emotional development of the child, and it creates a trust factor in the child, which is a very important factor, because in later life it leads to the confidence of the, it increases the confidence of the child in the later life. So these all factors are an important part and parcel for the breastfeeding phase. So breastfeeding is not
plays
only
a very, very critical
yes,
role.
it is not only important for the child, it is important for the mother as well.
Yes. So my next question goes to Charu. Said, how does nutrition during pregnancy influence the health of both the mother and baby, and what should be the priority in pregnant women's diet? So we need to focus on women diet, pregnancy diet.
Okay. So, see, it is important that for both mother and for the child. For mother, because the child is going to extract the nutrition from the mother, right? So if mother nutrition is not good, so it's just like a base. So a woman undergoes a lot of changes in her lifespan. So if the diet and the nutrition is not healthy, later part when she achieves menopause, etc., deficiencies may crop in. Specifically when I talk about mother, the diet has to be energy and protein dense. Because if it is not energy and protein dense, because the metabolic demand has been increasing in pregnancy, so she may feel weak, she may feel fatigued, and there would be changes. Secondly, the calcium intake is very important for the bone and the muscle health. The child may get the calcium from the mother, but if the mother's diet is deficient in calcium, her bones are going to get weaker and her chances of getting osteoporosis in the later part of the life when she's near menopause is higher. For her own immunity, diet plays very important role, because if her diet is not good, she is prone to illness and infection during the pregnancy. We heard our previous speaker saying that a lot of medicines are contraindicated. We don't want a mother to land up into any illness or infections during her pregnancy. Her proper appropriate weight gain is also important, because nowadays we are conceiving late in the life, so gestational diabetes and hypertension cases because of a lifestyle are at an increase. So we don't want unhealthy weight gain in the pregnant. So we need to take care of a healthy diet for the mother. When it comes to a child, definitely growth and development is important. Her brain development of the child, the nervous development of the child, nutrition plays an important role. The child immunity, the nutritional deficiencies if a mother has at the pregnancy and the diet is not appropriate, when the child is born, nutritional deficiencies are seen from that time. So the weight of the baby would not be appropriate if the diet of the mother is not appropriate. So we need to focus on energy, we need to focus on protein, we need to focus on calcium, we need to focus on folic acid. So there are studies and evidence which says that even when a mother is planning to be pregnant, is not pregnant, the first prescription that a doctor gives is of folic acid to actually get away from the neural tube effect. So that is the importance of nutrition when it comes to pregnancy.
So it has to be very, very balanced into terms of macro and micronutrients, all the neuronutrients or bone development nutrients or immunonutrients and all that needs to be balanced out. So very interesting question to Sandhya now. There are very common cultural misconceptions about maternal and child health that need to be addressed. As like when we are living in a country like India, we have lots of misconceptions. So to be addressed to improve the outcomes. So what are those and how do you manage while counseling a patient?
So there are some myths right from pregnancy itself. The one of the misconception, eating for two, and then things like milk is not good, yogurt is not good, or there is this concept that before the delivery they are supposed to be having lots of ghee.
Yes.
Because if they have a lot of ghee, the child is going to slip out. So those are the myths during pregnancy, but thankfully during pregnancy
Not
the body
eating
is so
papaya or
smart.
something.
Not having papaya, again
Pineapple.
papaya is something, because see, raw papaya has papain seeds. Now there's some studies to say that papain can cause contractions. So that is why, it is an old age myth, including a lot of gynecologists who tell our patients not to have papaya. Now, if you remove the white portion of this and the seeds totally, papaya is going to be safe. But a lot of times when the patient is already, so we don't just look at the physiology, we also look at the psychology of the thing, because we know it's not just papaya, it's various other fruits that we can give. Okay, similarly, nowadays in current context, we have to ensure that alcohol, smoking, these are some lifestyle changes that we need to. Also, you cannot work out, you can't do a regular routine, is another myth. You don't have to have a bed rest unless your doctor has asked you to rest. Because of some complications during your maternity period, you are not supposed to be resting. You can do your regular activity, you can do your exercise, you can do your walks, everything can be done during pregnancy. So that's something. What is most important is after the baby is born. So these are something when you're pregnant. After the baby is born, one of the major misconceptions that the mothers have is, my milk is not sufficient. I am not getting enough milk, and as a result, they start feeding the baby the formula feed. So conceptually, it is not possible not to have enough milk, and that requires a lot of confidence from the pediatrician, from the gynecologist, from the dietitian and the lactation experts to tell the patient, the lady, that you will provide enough, because the colostrum initially, the first day the milk production is going to be less. Colostrum is going to be protein dense, which is loaded with immunonutrients. It is going to be important for the baby's later on immunity development. So that's something that we need to emphasize. If the baby is growing adequately, which means that gaining approximately 500 grams of weight every 20 grams per day and about half a kg per month, that means that per week, sorry, that means the baby is growing adequately, and if the baby is passing urine regularly. So these are the very common things, because what happens is whenever the baby is going to the doctors, we monitor on the growth chart. There is something called WHO growth chart, wherein we plot the baby's weight and height and see whether the growth is adequate or not, and how much of urine is the baby passing, because that's something that we would know. If the baby is passing 7 times of urine, or if there are 6 to 7 wet diapers, that means the baby is having enough breast milk. So that is something that we see still. Also, post-delivery, and that is the reason when I go in my consultation and when I meet the lactating mother, I make it a point that the mother-in-laws are around, because they tend to feel that earlier times probably they used to feel that the mother is only supposed to have khichdi, dalia, lighter vegetables, and they used to think about shira hi lena hai, or fruits nahi kha sakte, wo thanda hota hai, uski taseer hoti hai, something, you know. So these are दूध बहुत पीना है, चावल नहीं खाना है, and वो लड्डू जो होते हैं हमारे पंजीरी के लड्डू and गोंद के लड्डू, now some of them make sense, okay? The nuts, the guar gum, these are called traditional galactagogues. We say it makes sense for you. Galactagogues are something which helps increase breast milk production. Excess plenty of fluid, it makes a lot of sense because it helps into milk production. But excess ghee and sugar in today's time does not make sense. I think in earlier times when women were not provided for, they had that scarcity. This was a provision for them. मैं हमेशा बोलती हूँ पहले कम था तो उनके लिए अलग से निकाला जाता था. हल्दी curcumin is very good because it also helps you build your immunity and आपको ठीक करता है. So that makes sense. But overdoing calories, what happens is the lady does not lose the excess weight and she doesn't understand eating healthy, and that's not helpful. So healthy balanced diet is going to be important for the mother during pregnancy, during lactation, and breastfeeding is one thing that all of us have to be talking about in totality, because if you start giving formula feed right in the beginning, the baby will not learn. It's easy for the child to have formula feed. It fills them up and they don't learn to suckle, and they become kind of lazy, if I'm not wrong. So which means that for successful lactation, we have to give exclusive breastfeeding in the first 6 months.
Thank you, Sandhya.
Can I add something? So I would also like to add that first you need to find out, nowadays cesarean section rates are going up higher. In normal delivery, the requirement of calories is more. So as a dietitian, you should know what kind of delivery a mother has undergone. And that also makes a difference in the kind of food and the diet that you would be giving to a mother. That is also something that you need to check. And also check the background of the mother. What has been the weight previously? What was the condition previously? And what is the condition now? That will make you decide what you need to guide. But definitely breastfeed is the golden milk that one should be promoting.
So the message which we are giving is like the myths which have been prevailing earlier, they were all not correct. And the practice considerations, certain old practicing like eating guar gum or eating nuts and seeds, that is good. But we need to educate or counsel our patients that how much to eat and how much do they require. That's it. That's the message we are getting.
Okay. So we need to counsel our patients to basically burst all these misconceptions. So my next question goes to Ms. Sonia. Like, what are some solutions or strategies which you normally apply for these newly mothers who are experiencing some latch issues during the first few weeks of breastfeeding, since breastfeeding is very, very important, we have understood. So how do you initiate or help these mothers out?
Right, so I know everybody has spoken a lot about benefits of breast milk, benefits of breastfeeding. Now the important part that comes as a lactation professional is that the baby is feeding, but the mother still feels the milk is not enough. So because we have to see, and what do we do as a nutritionist or as a lactation professional? We give them a lot of 𝐂𝐞𝐥𝐿 like milk boosting products so that mama makes more milk. But we often forget the basics of breastfeeding, that how is the baby latched. And being being a people of this society, we should all understand the basics that baby having breast into his mouth is not breastfeeding. There should be optimal milk transfer should be happening, and there are certain signs about it. So when a mother is feeding her baby, there should be no pain in the nipple area. That ensures that the baby is having optimal milk transfer, because if the baby is latching on the nipple is just like a shower spout which has holes, the milk comes out from that. So baby has to suckle on the dark part, the areola part, so that the milk optimally can be transferred to the baby. Likewise, you said the baby's weight gain and the baby's urine output are two important factors which ensures that whether the baby is having enough milk or not. So 6+ urine is advised, and 125 grams to 500 grams per week should be the weight gain, so that ensures that the baby is having enough milk. So the moral of the whole question is that, first of all, educating the moms about the signs of adequacy. Secondly, establishing a good latch so that they know that how to achieve an optimal milk transfer and they do not feel that their milk is less.
Okay. So it's not about only breastfeeding, it's about proper latching, latching at optimal milk transfer. That is very, very important when we are talking about this. So, Binu, my next question is, like, we understood that nutrition plays a very important role during pregnancy, during lactation. But if we consider a newborn's life, which is going to lay foundation for the future, so what are those, like, how do the mother should feed in those early days for these newborn kids for their long-term physical and cognitive development? What should they include into the diet of these newborn infant? What should be there?
See, majorly, as already it has been talked about, like diet for the mother is also important, but it is very important to look for the calories, and for the calories coming from carbohydrates, from proteins and fats. That is an important part. One thing is this, as earlier also I have told that because all the development of the child will be taken place in this few months, starting of the few months. Like brain development will be there, cognitive development will be there, motor skills will be there. So as coming to the motor skills also, because sucking and grasping power, that they start with the breastfeeding. So that is an important essential part, and after that they start with when their head is settled down, the moment of the head is settled down, then they start with the other motor skills also. For all those skills, nutritional impartment is very important, and it all goes from the breast milk. That is an important part. And other than this, emotional development is again an important part for this. So all these are these development are in the initial phase of the life, and they basically they base the foundation for the later life issues.
So any specific nutrients which need to be taken care during the early infancy time period?
For the mother, it is majorly for
the child.
For the child, because all the nutrients, if a child is breastfeeding, so all the nutrients are coming from the mother. That is an important part.
And in case of complementary feeding or the weaning?
In case of complementary feeding, yes, after 6 months of exclusive breastfeeding, a child must start with the complementary feeding. Now, there are an important part when we are starting with the complementary feeding. First thing is we start with the pureed vegetables or fruits such as mashed sweet potato or mashed potato or mashed apple, because this is the first thing which we should start. Now in this also, it's an important part that these things should be started one by one. One by one food should be introduced in the child's life. Along with the complementary food, breastfeeding is it can be reduced, but it not to be stopped till 1 year of the life, because it is an essential part of providing the nutrition to the child. And so all these complex carbohydrate should be introduced accordingly, like all the fruits and vegetables, and then slowly and slowly, regularly, gradually, we can go up to the semi-solid foods such as your khichdi, which is again packed with proteins and carbohydrate, because that provides you the all essential amino acids. That's an important part. So khichdi provides you all the protein and carbohydrates. And along with that, then slowly and slowly, gradually, it can be increased to other food introduction also.
Okay. So I'm moving to the last round for our panelists, and then we'll open for the audience the questions. So just moving a little more deeper understanding about the things which we have been discussing. So my question goes to Charu. So we have been talking about various, macronutrients and micronutrients. You've already spoken about the diet also part, which is important from the pregnancy point of view. Do you have recommend specific nutrients during pregnancy, like omega-3, iron, calcium, or vitamin D during pregnancy, or like certain specific sources, nutrition sources, which you are making it out, a must to be included into the plan, or
Yeah.
probiotics or something like that?
Absolutely. So first, as I said, folic acid. As soon as a mother goes to a gynecologist that she is pregnant, the first nutrient prescription that goes is of a folic acid.
Any
What
sources?
the
like
dietary sources?
Yeah.
I would want to ask the students, they are MSc students. What are the
Yeah.
sources of folic acid? You should answer this. What will you say to the counseling mothers? What
Sources
are the
of
sources of
folic
folic acid? Students, it's an interactive session. You should answer. Anyone?
You can raise your hand.
Raise your hands. Folic
No.
acid sources, the
Sources.
dietary sources. You know brain function. What is the dietary sources of folic acid? Green leafy vegetables are the first thing when it comes to in your mind for folic acid. You all know it, right or no? You write that in your plans, right? When you plan a sample menu, yes?
Yeah.
So folic acid, green leafy vegetables, your cereals, your pulses also have some amount of folic acid. The first thing is folic acid that you should remember. Second is iron. Iron is specifically in the second trimester because the blood volume increases and iron is needed for what? For hemoglobin, right? And hemoglobin helps oxygen to transport it into the blood, and the blood volume increases in the second trimester. So generally what you see is a dip in the hemoglobin level of a pregnant lady. So you need to give foods which are rich in iron. And India is actually, like the world is actually undergoing iron deficiency anemia, right? So if a pregnant mother is anemic, so you need to focus on iron from the day one. And India is a vegetarian population and country. So there are not many iron sources, right? What is heme iron? Any one of you?
What is heme iron?
Heme iron? Heme iron is from
No.
animal sources.
From
And
animal
non-heme iron is plant sources. Which is absorbed better? Heme iron is absorbed better. So if a vegetarian mother comes to you, how will you enhance the absorption of iron? Correct.
Yeah.
And what will you not give? Tannins, right? So this is important that you should be remembering. Third is calcium, right? So calcium, why is it important? I answered it already. Bones and muscle, and also for a proper development. Vitamin D along with calcium is important, so that the balance of calcium and phosphorus is maintained if vitamin D is enough. Otherwise, if vitamin D, calcium and phosphorus balance becomes very important, specifically for mother, for preventing herself from osteoporosis later in the life. So what are the sources of calcium? Dairy products, sesame seeds, these are the sources. So a mother should be encouraged. Now a mother comes to you in first trimester and say ki doodh peene se ulti aati hai, because these are the things, and nowadays not many mothers. So what will you counsel? Calcium is important. You'll have to educate the mother why you are talking about calcium, rather than just writing a pill of calcium. Dahi is also a source. Kheer is also a source. Custard is also a source. As a dietitian, you will have to give alternatives. Sprinkling sesame seeds on salad will also have her calcium intake enhance. Broccoli and certain other vegetables which have little calcium, you can ask them also to eat. Then coming to omega-3 fatty acids. What omega-3 fatty acids will enhance what? Brain function, cognitive function, right? So what are the sources of omega-3 fatty acids? Nuts, seeds, and what else? What oil has omega-3 fatty acid? So seeds, nuts, a rural section, a poorer section will not be able to afford seeds. Fish is a very good source of omega-3 fatty acids. Now the poorer section who will not be able to afford nuts, fish, and seeds on a regular basis, what is the oil which is rich in omega-3 fatty acid? Fish oil, we don't use fish oil for cooking regularly.
In North India, you won't use, no?
You don't use fish oil for cooking, no? How many of you? What oil is rich in omega-3 fatty acids? Mustard oil. So that is also that you can prescribe to a pregnant lady. So these are the nutrients.
Yeah.
That
So while we are prescribing all these good sources, we should also talk about some nutrient interaction also.
Yes.
So like Madam told that iron has been best, absorbed if we are including vitamin C. Some student has also shared, and tannins should be avoided. So we should always consider that if some important nutrients need to be added in diet, and we are talking about the sources for them, so we should always be having knowledge of nutrient and nutrient interaction also, when to give, what other things to be avoided with these, and how to include. It's not like the sesame seeds Madam has told about giving for a good source for calcium if the mother is not having milk as a source for calcium. So you can't give it in bulk. The portion sizes and the other things also need to be managed. Yes,
Absolutely.
millets are good sources for many of the essential nutrients, so they can be included in the diet. Okay. So it was a wonderful, interaction with the students in this question.
Protein is also important. Yeah.
So we are majorly, like, if we talk about over here in North India, we are carb eaters. Okay.
I just wanted to add cow milk protein allergy. So these days it's very common that you are prescribing milk to the mother. Mother is drinking a lot of milk and the baby is getting allergic to it. So please just do it in moderation, because babies these days are getting cow milk protein allergy. If the mother is intolerant to the lactose, it comes to the baby as well.
Any alternative sources for the cow's milk somebody wants to suggest? We have diet.
Of course, when we are talking about cow's milk, you will have to look at soy milk. There are soy milk. You can use almond milk. A lot of people buy almond milk from outside. The way I tell my patients is that you can make your almond milk at home itself, or probably just eat almond for that matter. Okay, but soy milk is a good option for you.
If the person is not from that, status.
And
like
it should be calcium fortified. Always look for calcium fortification
soy
soy
milk
milk.
with
Yeah.
calcium fortification.
Yeah. And no sugar added.
Okay. So because many, patients do think that this the packaged milk is also not a cow milk or buffalo's milk. They think it to be a soy milk only and consuming that instead of the other milk. So my next question goes to Sandhya. So we have initially also discussed. Now I need to understand from you, how do the nutritional needs of a premature infant differ from a full-term infant? And what should be taken to ensure that they are receiving the adequate nourishment?
So this is quite a complex bit actually, because if the baby is preterm, there are two conditions. If the baby is called preterm, if the baby is delivered before 37 weeks. Now from 35 to 37 weeks, the baby is doing all right. But if the baby is preterm, which is less than 32 weeks of gestation, that's a critical situation. So less than 32 weeks and less than 1500 milligrams of 1.5 kg. If the baby is less than that, that means the baby's requirement is very high. Now the requirement is high as in a normal baby, full-term baby would require anything between 90 to 120 kilocalorie per kg body weight. But these babies would require higher calories, as high as 120 to 150 kilocalorie. Protein requirement also increases. Normal babies would require anything between 2.2, but this one may require as high as 4 grams. Not just that, because the third trimester, the last trimester gestation, is the time when the stores of fat stores are there. So these babies will require more calories, more proteins, more fats for the growth to kind of come back to the weight. And they have immature excretory system, they have immature systems, immune systems. So which means that it is very important that the nutrition is made enough for the baby to catch up to what the intrauterine growth would have been. So in these cases, now it depends what stage and what state and how early the baby has come in. If the babies, so again, monitoring is very important, and majorly these are in neonatal ICUs, the baby is really sick or low birth weight baby. In such cases also we say express breast milk. The beauty is that the preterm baby's mother's milk composition has higher calories and proteins. Though if the baby is too small, it would not be sufficient for the baby to catch up the growth. We may still want to add the human fortifiers, that human milk fortifiers into the baby's, the mother's milk. But otherwise what we'll do is, the first goal is to give express breast milk. Again, give that, monitor the growth of the baby. If the growth is not, and if once we reach the target of, again, it is like you have to first, and very low term babies, you may have to start total parenteral nutrition. We'll start with parenteral nutrition, then simultaneously give enteral nutrition, which would be express breast milk. If express breast milk is not there, then we have milk banks, pasteurized donor milk banks, whereas, and in our hospital also we get that from there. Because then the immunoglobulins and IgA and all the things that we spoke about, the baby needs it more because the baby is preterm. Then we have to increase the target. So basically, reducing the TPN, increasing the EN, and the calorie, protein, and electrolyte requirement and the fluid requirement is higher. So for the preterm babies, the fluid requirement goes as high as 150 to 180 ml per day. So once we reach 100, 120 ml, in that case, we have to have human milk fortifiers. So TPN, EN, express milk. If not express, mother cannot give, then we will have to go to the banks, then we'll have to add human milk fortifiers, and keep on monitoring the growth of the baby to go to on and fro. In the entire case, everyday monitoring of how much is the intake output, how is the electrolyte balance, all of that is monitored till the baby starts learning to latch on and start feeding the mother's milk. Awesome. The goal is to put the baby to the mother's milk, and the baby starts having that naturally. So that's something. So it's very, very complicated, and it has to be done by the neonatologist. The dietitian also has to participate in the whole process, and that is how we go about the preterm babies. Also understand the micronutrient requirement, the vitamin D requirement, for that matter, iron requirement, calcium, phosphorus, all these are higher for preterm babies. We may have to supplement these. So there are IVs that we'll have to give, and all the human fortifiers and trace elements also are added there, so zinc, selenium. So these are the things that will have to be monitored and titrated depending upon how premature the baby is. It gets very critical when the baby is lesser than 32 weeks of gestation. Beyond 34 weeks of gestation, it's still manageable, and we can certainly keep on monitoring and do with our breast milk that we give.
Excellent. So Binu, my last question to you is, like, you've been talking about the breastfeeding and the complementary feeding. Can you give us some signs that a baby is ready to start with the weaning, and how we can make that transition as dietitian while we are counseling from breastfeeding to this complementary solid foods or other foods which have to be included in the diet of the baby?
Yes, actually, after 6 months, because during the 6 months, the signs which are shown by the baby are, first is the settlement of their head movement. When the head movement is settled, after that, weaning mostly starts. Like, it is approximately 6 months. Head settlement takes place around 2 to 3 months. And then as the gradual setting of the body and other functions are also evolved in the baby, and then after 6 months, baby start for the complementary feeding. One is this, in fact, the feeding also takes place differently during that phase. And another thing is that
Any
baby
specific
asks for the
tips to start on with the complementary feeding, that
Yeah,
what are the initial foods
that
which
I'm
need to be
coming to
included?
it, because actually what happens is there are signs. Baby feels more more starved after taking the breast milk also. Then also it comes to know, and baby shows the like when the mother or caretaker, whoever is taking care of the baby, baby show, because they are seeing the signs also that mother is eating the food. They are showing the signs also. So all those signs refers to that the weaning has to be started, and after 6 months, yes, weaning has to be started, but it has to be gradual. First of all, it has to be started with the, as earlier also I have told, that pureed food should be introduced initially, and moreover, one food is to be introduced at one time, because
There should be a gap between first food and the new food which has to be introduced?
yes, there should be a gap of
How
at
much?
least 5 to 6 days.
Okay.
One food is introduced, then 5 to 6 days there should be a gap at least, because the child is the child has started taking that food and accepting that food, so it takes time. Another thing is, this also leads to the parents to know that if a child is having allergy also, any allergy to any food, because we are starting a food one by one, so it leads to parents also that to know about if a child is facing any allergy to any particular food. So that's why it should be started gradually, and later on gradually all the other foods should be included in the diet, like millets can be included in the form of the porridge or along with the milk, mixed with the milk. Then the mixed food should be introduced, and in the weaning phase, along with all these things, complementary food, breastfeeding should not be stopped. It should be continued till first year of the life. It is compulsory to continue. After that also, as per the WHO, also like it should be continued till 2 years of the life, but it depends according to the mother and child also. And another part is like when the breastfeeding, when we start with the complementary feeding, because initially 1 or 2 meal only can be given as a complementary feeding along with the breastfeeding. So later on gradually it increases.
Okay.
So I just add, for 6 months, the exclusive breastfeeding. For 1 year, roughly half of the nutritional requirement is met through the breast milk. Half of the requirement would be met through complementary or food from outside, food from home, or whatever the baby is having other than breast milk. And the second year, 1/3 of the requirement is met through breast milk, and the rest of the 2/3 is met through the food that is given. And diet diversity and food diversity, millets, nuts, seeds, all these things are going to be encouraged as we start introducing the food for the
And
children.
one more thing I would like to add into this is, nowadays as per the WHO recommendations also, earlier we used to, like the sugar was introduced, but nowadays it is specifically said that refined sugar should not be introduced in the complementary feeding. Instead of refined sugar, we can use the natural sugar which are available in the form of the dates or honey or raisins. We can add those things into the complementary food, whatever is prepared for the child. But refined sugar should not be introduced in an early age of the life.
Also, I would like to add over here, it is the consistency. Even if it is an educated family, like we have seen patients in our OPD coming, giving a liquid consistency to a 1-year-old child also. So as age grows, the consistency of the food also has to change, and it also enhances the self-feeding of the child should also be encouraged, so that the motor skills of the child also develops. Like I saw an underweight child at 1 year, and the consistency of the food that was given was, the mother-in-law who was a caretaker was actually had increased the nipple size of the bottle and was giving complementary feed through the bottle only. So more water, less nutrition is what the child was getting. So consistency plays a very important role. Start with puree, then to mashed, and then to soft, and by 1 year it should be finger food, and the food that is cooked in the family, that should the child should be able to consume that food by 1 year.
This finger foods and all these increases the motor skills also. This enhances the motor skills of the child also. So it is very important, the stage-wise, these things should be given in a complementary feeding, as the ma'am was saying, that initially pureed or liquid form should be of a very small time period, then pureed form, then semi-solid, then solid. And in between the finger foods can be introduced in the feeding process.
Thank you so much. So my last question goes to Ms. Sonia. So we have, I mean, like covered most of the things, but one thing which I need to understand from you, being a maternal counselor, like health is often overlooked during this period. So I would like to ask you, like, what are the most common mental health challenges you have faced or you've seen in your patients, like pregnant women and the new mothers? Also, another question along with that is, you've been practicing this since last few years? I mean, okay. Because the concept of initial counselors was not that much popularized. So, do you think that there are proven benefits of having a birth coach like you are doing the practices or during childbirth, both for the mother and baby? I just wanted to understand both the things.
Thank you for this question, and I would like to start this as a mentioning myself. I am a postpartum depression survivor
Okay.
myself,
Oh.
and that's what led me to start this journey of supporting and educating mothers in those most vulnerable part of their time, because pregnancy is like, you know, they are babies inside, they are living their life. Once the baby comes out, the whole life changes. The life is all according to the baby.
Yes.
And it's no wonder that the mom feels exhausted, and because the reality hits her in the face. So being an educator, I'll just start from the backside, because being an educator, I do show this window to the parents, to be parents during pregnancy, that what you can expect after the birth of the baby, because knowledge is always power. Information always makes us feel safe. So when they have this information, what to expect, how they can take care of themselves, how they can take care of their baby before the arrival of the baby, that really helps them to at least be in control or take charge of the changes that are going to come up with the changing time. Now, coming to the mental health part. These days, we hear a lot about mental health challenges. It is not something new that has happened. It has always been there because of the hormonal changes that happens during pregnancy and after the birth of the baby as well. And if you say, like, it's like a, you know, hormones ka tadka, that everybody in the house can smell it, that okay, something is going on. So the mother's mental health is always it has been there, but it was always overlooked because everybody was so busy in taking care of the baby, everybody overlooked the mama. And then they always thought that it is the, you know, maybe she's more cranky, she's sleepy, that's the reason. But emotional support, the non-judgmental emotional support given to the mom. So what we think is, family ने खाना खिला दिया, mother को हो गया. This is the care a mother should get. बच्चे के लिए भी क्या है? जब बच्चा रोया, खाना खिलाओ, दूध पिलाओ. And most of the time it's not low milk supply, it's always that why is the baby crying. So there are a lot of evaluation that has to be done. So mother's mental health these days, when you said that change of hormones, change in the life routine, changes you know, in the family, and new demands of new baby, they always look like overwhelming, and mothers get exhausted, and lack of support, like you know, physical support in terms of, you know, taking care of the baby. They cannot do it alone. So that is the major cause of what I understand about the reason for the postpartum depression, or, you know, these days postpartum blues can lead to postpartum depression.
So
and my role as an educator and as a birth doula, definitely, because they are being supported as you know, during pregnancy and birth. So definitely it helps them overcoming those challenges.
So definitely playing a very, very important role, as all dietitians, doctors are been doing. So initially this part was, I think, lacking, and doctors do not have that much of, I mean, they also have some time constraint for counseling patients for such a longer time. So with you being at, in the hospital, and the people who are facing challenges, they can always reach to you for the counseling part. So from my side, the questions are now been open for all the students if they want to ask any question to our panelists. It's a good, chance to interact with them. Yeah, please.
So what I meant here was when you are actually undergoing a normal delivery, and those were the days when normal deliveries were multiple, right? And the female were not given appropriate nutrients. So things like 𝐂𝐞𝐥𝐿 panjiri were the energy dense sources which were given to a female to get rid of fatigue. But nowadays, a mother is undergoing LSCS. Even if it is normal delivery, then it is a birth of 2 babies. Not many babies are done. And a female is eating food appropriately as per what a man is eating in the family. So the nutrition difference is not there. But what I meant was you need to understand how many deliveries a mother has undergone. So if it is a 4 or a 5 delivery, regular delivery, so definitely the nutrition demands are higher. That is what, as a dietitian, you need to understand the entire history and then plan your diet. If it is a 2 delivery and the gap is appropriate, mother has enough good lifestyle, the eating pattern is good, everything is same. It is not that normal delivery you need to eat this many calories, C-section you need to eat that many calories. That difference is not there. But it is depending upon what your BMI has been. Of course, the fat has to be cut down for the normal also. Fat as a in the entire top panel discussion, we didn't talk about fat as a important nutrient. There is no need of increasing the fat calories. Initially, yes, as I told you, when mothers were not eating and multiple deliveries. Every year, a mother was giving a birth to a child. So you had to give energy-dense food. And energy-dense food, fat is an energy-dense component. Hence, that was incorporated in the diet. But today's era, in urban societies, it is not there. But in certain rural section, not the rural sections which are nearer to the urban areas, not that, the real rural section, there the role of fat would still be existing. So assessment becomes very, very important. So that's what I wanted to say. So fat increasing is not required, but panjiri with less fat, no sugar. That's what I tell my patients. Have the use of gum, guar gum that they add. That is definitely a good 𝐂𝐞𝐥𝐿, which is important.
So we should basically focus on quality of fats.
Yes.
Not the quantity. I mean, the quantity needs to be that same that we have been prescribing as per the guidelines, but that has to be managed as per the tailor-made. But the good quality fats, that should be the part of the diet.
We can add more of the millets. Instead of only the wheat, we can include the millets and we can include the besan also. That will increase the protein quality of the particular food also and the healthy fats also, including more of the seeds into it.
So I think it's a myth for people who have not understood it. C-section, the lady comes, कहते हैं नहीं जच्चा है, इसका अभी सर्जरी हुआ है, इसको दूध मत दो, इसको दही मत दो, इसको तेल मत दो, बेचारे को सिर्फ खिचड़ी खिलाया जाता है और वो लेडी भूखी रहती है. So if she has undergone a C-section, she can still eat and absolutely. So in our hospital, the lady delivers. First meal is given as a soft diet because अभी surgery से निकल के आई है. Feeding हमारी शुरू हो जानी चाहिए right in the first hour. The breastfeeding has to start in the first hour. And then we give one light meal and we give full-fledged normal khana, which means rajma, chole, lobia, kale, neele, peeli, whatever, dals, nuts, seeds, everything. Of course, it all depends upon her own digestion. अगर वो पहले से कुछ चीज़ें नहीं digest कर पाती थी, she'll continue to have the same, and she's lying down on bed, not that active, she may not. So it's a myth not to give fat to C-section patients. Thank you.
Thank you. Any more questions? Okay. So with this, we can close. Thank you all the panelists, and thank you audience for being the patient listeners. Thank you so much.
If we just can request all the panelists to please stay over so that we can just, give the rewards to the winners, quiz winners. A heartfelt thank you to all our panelists for this thought-provoking discussion. Today has been a wonderful reminder of the power of early interventions and quality healthcare, and the role that communities play in ensuring the health and well-being of future generations. It's now time to announce the quiz results. The first reward goes to Vanchika Sethi from MSc NND second semester. May we please request all our experts to give away the reward. The second prize goes to Sejal Ahuja from MSc NND 4th semester. May we please request Divya ma'am to please join us on the stage? Is Sejal there? No, okay. The third prize goes to Shalini Bhati from MSc NND 4th semester. Please join us on the stage. And the fourth prize goes to Vritti from BSc NND second semester. Congratulations to all the winners. Can we please request all the winners and all the faculty members to please join us on the stage for a group photograph? All the winners, along with all the faculty members, please. I would now like to request Dr. Pratibha Singh, ma'am, Professor, Department of Nutrition and Dietetics, to present the vote of thanks.
very good afternoon to everyone. It is both an honor and privilege to extend the vote of thanks on this momentous occasion as we conclude our one-day seminar and panel discussion organized in celebration of World Health Day 2025. First and foremost, although ma'am has gone, but a heartfelt thanks to our distinguished speaker of the day, Dr. Divya Kumar from Accord Super Speciality Hospital, Faridabad. Her perspective on pregnancy have not only deepened our understanding of global and local health issues, but have also inspired action toward more equitable and inclusive healthcare. Next, today's panelists, Ms. Sandhya Pandey, Ms. Sonia Rai, Ms. Beenu Bhatia, and Ms. Charudua ma'am, who brought depth and expertise in session, your perspective on exclusive breastfeeding, maternal and child care, mental health, and preventive strategies have enriched our understanding and inspired us to reimagine our roles in shaping a healthcare tomorrow. Thank you all the panelists for insightful discussion on the given theme. Special thanks to the moderator of the panel discussion, Ms. Shilpa Thakur ma'am, who managed every detail of panel discussion with grace and professionalism. I would also like to express my gratitude to the organizing committee, Ms. Divya Puri and Ms. Mehak Katyal, whose tireless planning and coordination under the able guidance of Dr. Divya Sanghi, Head Department of Nutrition and Dietetics, and our PVC, Dr. Puneet Batra, ensured the smooth execution of today's program. Your commitment to this cause is commendable. To all the participants, students, and my fellow colleagues, thank you for your enthusiasm and engagement. Your questions and reflections throughout the day have made the seminar not just informative but interactive and impactful. As we disperse, let us carry forward the message of healthy beginnings, whether in our families, our communities, or our institutions, and work collectively towards hopeful futures and prioritize health well-being for all. Let us move forward from the day with renewed commitment to make health not a privilege but a fundamental right for everybody. Thank you once again, everyone, for participation, and congratulations to winners also. Thank you.
Thank you, ma'am. Have a wonderful day, and let's continue to work towards making this vision a reality. May I now request everyone to please raise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all. The students may now proceed for their classes.